¿Estamos en silencio?
Okay. Yeah, good afternoon, good evening to all of attendees. Today, we have a super interesting topic with the highest level of scientific evidence. First of all, I thank you for your presence and especially thank to IFSO Latin American chapter for allowing SACO to organize this event. We open the microphone to Dr. Luis Poggi, President-elect of IFSO Latin American Chapter, for a few words of welcome. Luis.
Gracias, Pedro. Buenas tardes y buenas noches a todos. Encantado de realmente dar la bienvenida a esta organización de la SACO a nombre de IFSO-LAC, por encargo de Estuardo Vélez, presidente de la sociedad, y dar la bienvenida a nuestras queridas doctoras que nos van a ayudar a organizar esto con la presencia muy importante de Francesco Rubino, quien va a estar encargado de poder darnos muchas luces, y creo que este webinar nos va a servir a todos para poder escoger mejor nuestros casos frente a pacientes diabéticos que requieren de una especial y más sensible selección. No quiero abundar más porque creo que es muy importante lo que tenemos que escuchar, y solamente agradecerles la oportunidad de dar a nosotros la introducción a este webinar, que estoy seguro va a ser del interés y de la importancia que queremos que todos tengan en estos eventos. Adelante, Pedro. Gracias.
Gracias, Luis. Now I have the pleasure to introduce the speaker of the night, Dr. Francesco Rubino. He's a professor of metabolic and bariatric surgery at King's College London, at consul surgeon at King's College Hospital in London, UK. His study provided the first experimental evidence, evidence that the anti-diabetes effect of gastric bypass surgery results from mechanism beyond weight loss, offering a biological base for metabolic and diabetes surgery. He was also the main organizer of the Diabetes Surgery Summit, an international consensus conference that in 2016 developed global clinical guidelines for surgical treatment of diabetes. Dr. Rubino received his MD and completed his residency in general surgery at Catholic University Policlinico Gemelli in Rome, Italy. He completed fellowship in laparoscopic and minimal invasive surgery at the European Institute of Telesurgery in Strasbourg, France, Mount Sinai Medical Center in New York, and at the Cleveland Clinic in Cleveland, Ohio. Before joining King's, he was chief of gastrointestinal metabolic surgery at Weill Cornell Medical College and New York Presbyterian Hospital in New York. Dr. Rubino, thank you very much for being with us this evening. The audience is all yours. You are mute, Francesco. Francesco.
Yes. Good evening. Buenas noches. So sorry I don't speak Spanish. Wish I could speak Italian. Maybe to some of you may not be difficult to understand. I'm sure many of you will understand Italian, but my Italian has become not as good after many years abroad. So I'm sorry if I'm going to end up speaking English tonight. So I really want to thank SACO and IFSO Latin America for this invitation, especially because I have the opportunity to present. This is the first time, actually, indeed, that I present the data that we just published in the Lancet about our randomized clinical trial. And I'm happy to present this to an audience and a panel that includes both surgeons and non-surgeons, as I think this is really about diabetes and management of diabetes. And so it is a problem that goes across the board and across specialties. It's certainly not just only a matter of surgical interest. So the slides showing my disclosures, I'd like to just recognize as the first thing that this is a paper just published a week or 2 weeks ago in the Lancet, and reports our 10 years follow-up of a randomized clinical trial that compare metabolic surgery and conventional medical therapies plus lifestyle interventions for patients with type 2 diabetes. This was an open label, single center randomized clinical trial. I want to acknowledge right away my friend and colleague Geltrude Mingroni, who has been the endocrinologist co-PI with me of this study. She works in Rome, but also at King's in London, and she has been involved on the ground to follow up these patients for so many years. So for a study that has such a long-term follow-up, I think much credit has to be given to her. My role in the study was as a co-PI of the study to design the study with Geltrude back then in many years ago. At the time, I had an appointment also at Catholic University of Rome and Policlinico Gemelli, where the patients had been operated. And even if I was working in New York City, I was flying to Rome, which was always a pleasure for me going back home. And I was operating patients there for this trial. So this was many years ago. We have published the first 2 years outcomes of the study in New England Journal of Medicine in 2012, and then the 5 years results in 2015 in the Lancet. And now these are the 10 years follow-up data, in again published just in the Lancet 2 weeks ago. As a very brief background, I need to say that why this is an important study and follow-up, because so far we have several randomized clinical trials in this field. We have 12 randomized clinical trials, but none of them has reported so far data results beyond 5 years. Now, even though of course, we want to see longer term data all the time. In 5 years is good, and if we can do more, it's always better. I think it's important to recognize that 10 years follow-up in randomized clinical trials is not happening very often, especially in surgical trials. It's very difficult to follow up patients for so long, and especially in trials that maintain and randomize patients between surgery and non-surgical therapies. There are very few studies, not just in metabolic, there's no studies in metabolic surgery so far, but there's actually very few studies in any surgical discipline that has 10 years follow-up at this level. So I think it's important to underscore how the level of evidence that now exists for metabolic surgery, with 12 other randomized trials with results by between 2 and 5 years, and now one of these trials reaching 10 years follow-up, is very probably safe to say one of the strongest level of evidence that we have for any surgical operation, for any use of surgical operations for any other disease. So certainly the field of diabetes and obesity now is one of the, where the use of surgery can be more assessed much better than maybe surgery for many other diseases. Here is the consort diagram of the study. This was a small study. We recruited 60 patients. The reason why the study was small is because when we designed the study, our primary endpoint was the diabetes remission. And by all knowledge that we had at the time, based on the anticipation of what remission might be, the remission rates might be, the study only called for 60 patients. And so that's the reason why the size. But importantly, I have to say that when the study was designed, there was a very new definition of diabetes remission that was established by the American Diabetes Association just a year before. Before that time, in bariatric surgery, we have seen reports with completely inconsistent way of assessing outcomes in diabetes. There were papers reporting on resolution of diabetes or normalization of glycemia, but very often there were no data about A1C. Some of these outcomes were judged on whether patients were or were not taking medications, etc. Very often there was no preoperative data about the duration of diabetes or other important parameters. So at the time we designed this study, remission of diabetes had been recently defined by the American Diabetes Association, and no study had ever investigated if that remission, that outcome could be achievable by surgery or any other therapy for what matters. Now, what we did was we randomized 1 to 60 patients to having either gastric bypass or biliopancreatic diversion or medical therapy plus lifestyle interventions. So gastric bypass was performed laparoscopically, and I was, again, going from New York to Rome specifically to perform those operations. In the hospital in Rome, there was a long-term experience by the local surgeons with biliopancreatic diversion. And this was the reason why biliopancreatic diversion had to be included in the study. The ethical committee at that hospital say that obviously for their perspective of the hospital, BPD was a standard of care and therefore had to be included in this study. And so we compared both bypass laparoscopically and open BPD performed by the local surgeons. Of note, this BPD is not the classic, it's actually the classic BPD according to the Scopinaro procedure, not the BPDDS where there is a sleeve gastrectomy. This operation involves a horizontal gastrectomy and a very short common channel of 50 centimeters. So in the classical Scopinaro operation, that was a standard at that hospital. Importantly, the medical therapy of the study was designed to be as current as possible over time. So the medical therapy was updated constantly throughout the 10 years of the study so that the new medications could be used as soon as they were recommended by the ADA, ESD, European Society for the Study of Diabetes, Association for the Study of Diabetes, and American Diabetes Association algorithms of diabetes care. So over the course of the 10 years, obviously medications changed so that over the last 5 or 6 years and 10 years and more, the medications became increasingly more weighted in terms of use of GLP-1 agonists as well as SGLT2 inhibitors, etc. So this is just as modern and as current medical therapies we could offer. In addition to medical therapies, there was a structured dietetic intervention that was with patients having dietetic input and support, being instructed about standard recommendations for physical exercise as well as diet for diabetes as recommended by European and American organizations. Now, what I want to underline here is that in this study, we started with 20 patients per group, and we have the ability to assess outcomes at 10 years on basically 58 of these patients. This is an extraordinary over 95% retention rate at 10 years, which is very remarkable Again, it attests to the skills and ability of my colleagues in Rome to maintain patients for so long. But it's a very important thing, especially because we have 100% of the patients who were in the surgical groups at baseline are available for assessment at 10 years. That means that for the assessment of the durability of diabetes remission, the study is very robust. We have every single patient that entered the study and had surgery was still here. In the 18 patients who completed, for whom informations were available at 10 years, we included 2 patients who crossed over to surgery after the first 2 years. In the intention to treat analysis, we have, for the primary endpoint, we have considered these 2 patients into the medical group, even though they, of course, crossed over to surgery and achieved remission after crossing over, but what they were included in the intention to treat as per rules of randomized trials. However, in the per protocol analysis, of course, those 2 patients were not counted. So, as well as the patient who also died in the, there was a patient who died from myocardial infarction. It was also included, it was available for assessment, obviously, but in terms of outcomes, but of course died during the course of the study for massive myocardial infarction. So the study is small, but the robustness of the study is the high retention rate that we had. Inclusion criteria involved age 30 to 60 years, BMI 35 and above, a history of type 2 diabetes of at least 5 years. This is very important because in bariatric surgery, historically, we know that there are only 20–30% of patients who do have diabetes in bariatric surgery. The majority don't have diabetes. And those who do have diabetes, the majority of them have very often early onset diabetes, recent onset diabetes. So it has been a very important point in many trials of surgery specifically done for diabetes that we have a more reliable and realistic population representing the population of diabetes. So these patients were all with full-blown diabetes from the outset, and all of them were at least on 1 or more medications and were not achieving the target of 7% hemoglobin A1C, which is the recommended target by diabetes organization. So by design, all the patients in the trial had full-blown diabetes and not adequately controlled by standard medication. So as they entered the study, the medication usage and lifestyle intervention was intensified in order to achieve the target of reducing A1C below 7%. The primary endpoint that I mentioned before was remission of diabetes at 2 years. This was defined according to the newly established back then, the American Diabetes Association definition, that required fasting glycemia less than 100 milligrams DL, and hemoglobin A1C less than 6.5% to define remission. Now I have to underscore that both of those parameters were to be met for our patients to be considered in remission, not just A1C, but both of them. And importantly, they had to have no medical therapy for at least 1 year. This definition is very strict, and I want to underline that it's different, for instance, than the definition of remission recently used in studies of very low-calorie diet, where the investigators used a if you want, arbitrary definition with A1C below 6.5, but with a lack of medical therapy for 3 months or less. So here it was the official ADA definition. And in terms of secondary endpoints, we looked, of course, at the durability of remission over time at 10 years. We also looked at glycemic control regardless of remission. How many patients were able to achieve the target of less than 7% hemoglobin A1C? We also looked, of course, at weight loss, blood pressure, lipid control, cardiovascular risk score, renal function, medication usage, quality of life, surgical or nutritional or metabolic adverse events, and very importantly, diabetes-related complications. These were all predefined outcomes of this 10 years follow-up analysis. Now, in terms of baseline characteristics, again, we had 20 patients per group. You can see there were no differences in significant difference at baseline between groups, meaning the randomization was robust in creating homogeneous disease across the three groups. I want to underline the fact that there is, in this trial, there is a equal split between male and female patients, which is also not the case typically of bariatric surgery, where there is a disproportionate number of female patients. This reflects the distribution of disease, particularly diabetes, across genders. In other important factor I want to emphasize from baseline is that these patients were all taking more than 2 medications, an average of 2.5 medications or more for each patient at baseline. And note that at least about 50% of patients in this trial at baseline were already on insulin. So we are talking about a substantial full-blown diabetes with significant severity of diabetes. We're not talking about early diabetes. So in terms of results, this is the graph that reports on the 10-year remission of diabetes. You can see that obviously there is no line for medical therapy because none of the patients in the medical therapy group achieved remission. However, in the intention to treat analysis, as I mentioned, we included the 2 patients in the medical therapy group that after 2 years crossed over to surgery. Among them, both of them actually experienced immediate remission after conversion, and one of them maintained remission for the other 8 years. So it's now counted as a remission in the group of medical therapy by ITT analysis, by intention to treat. But you can see that even with intention to treat, there is obviously a statistically significant difference with surgical patients, both groups being superior in terms of primary outcome. You can also see a difference between BPD and Roux-en-Y gastric bypass in terms of remission. Then now, if you look at the per protocol analysis, which obviously now reports the achievement of the outcome for patients who have actually received that type of interventions, each of the groups are distinct by medical therapy, BPD, or Roux-en-Y gastric bypass. You can see that about 37% of more than 37% of patients who underwent surgery in total between the 2 groups maintain remission for 10 years. I want to take the data of remission at 2 years was 70 and 90%. So then you can see there is a decline in remission over time, as you would expect with some patients experiencing relapse of diabetes. But I want to take 1 second to underscore this 37.5% of people who had type 2 diabetes, full-blown, severe, on multiple medications, 50% of them on insulin, and you do an operation at some point in their life, and for 10 years, there is no sign of diabetes whatsoever. Normal glycemia maintained with no signs of diabetes whatsoever. This is when I was a junior resident in New York as a fellow, actually at the time, a junior fellow in New York at Mount Sinai in 1999. That was the thing that made me pause and think for a moment. When I was reading old papers suggesting that surgery might result in resolution, as it was called before, of diabetes for long term, I wonder whether that could be a cure of diabetes. What does it mean not having signs of diabetes? The problem was that those old reports were not giving us a measure of disease at baseline. Many of these reports say patients had the diagnosis of diabetes. We did not have in most of these reports, even the most elegant ones, precise A1C levels at baseline, duration of diabetes at baseline, or fasting glycemia. This is a documented full-blown diabetes that does disappear and remains in remission for 10 years in more than 1/3 of cases. I continue to find this extremely interesting and fascinating, especially if you, like many of us, have been trained in medical schools and you've been told that diabetes is irreversible and chronic and incurable. I think this data have to give us a little bit of time to pause and think about the whether or not we should redefine diabetes as a chronic disease. Now, the question is, what happens to people who have relapsed, right? So, as I said, remission is highest at 2 years, and then after 2 years, there are some patients who relapse. It's still sustained in many patients, but some patients have relapsed. Now, out of the patients who relapse, what happens to them? First of all, when does remission occur and when does relapse occur? The first thing to notice that people who didn't have remission in the first 2 years have not achieved remission thereafter. So there is no long-term late remission. Either remission happens relatively early after surgery, or it will not happen afterwards. So that's a first important thing in terms of managing patients. But we'll look at what happened to the relapse of diabetes. This graph only looks at patients who had remission and looked at the incidence of relapse over the 10 years. What you can see here is that the vast majority, if not almost all, the relapse cases occurred in the first 5 to 6 years. There were basically no more relapse after that period. This is a very important observation because it allows to make some clinical considerations on whether people achieve, once people achieve remission for more than 5 years, the likelihood of achieving relapse becomes so low that one could wonder if managing these patients could be changed and done in a different way. Maybe we don't need to monitor these patients as frequently as we do in the first 5 years. Maybe we can relax a little bit the monitoring, at least making an A1C check every once a year, consider them as if they were pre-diabetic patients, but not necessarily having the routine screening that in many countries requires A1C checks to be done more often, maybe every 3 or 6 months. Maybe if you're in remission for that long, it is perhaps possible to relax frequency of monitoring. I'm not advocating not continuing to check these patients because it is possible that they might have new diabetes in their future. But it's very important to note this relationship between relapse and timing. I would say, obviously, even if patients are having diabetes after 20 years, one could consider that as potentially as a new disease. It's difficult to say if it's new disease or old disease, but for 10 years remission means it's a long time. It's really, really long time without signs of diabetes. Now, importantly, all patients who experience relapse, this is very important because people, when they refer to relapse, they think, okay, then after a while, the effect of surgery is lost if people get relapse. Well, let's look at the data. The data show that all the patients who had relapse in this study maintained glycemic control that one would arguably consider very, very good. The mean A1C level in the patients with relapse, not in overall, but in the patients with relapse was 6.7. And all patients but one had A1C below 7.1. 0. Now, if you remember, I told you that at baseline, every single patient had A1C above 7 with multiple medications and even in requiring insulin. I mean, I think this means that even when you relapse, it's unlikely you go back exactly to square one. Most patients, some patients might, but most patients actually have much better control of diabetes, even if they don't maintain remission throughout 10 years and beyond. Here is the level of A1C regardless of remission. This is the A1C over time. You can see that there was a statistically significant difference in terms of A1C, average A1C between groups with favoring surgery. Importantly, the change from baseline was quite significant. You can see BPD patients at 2.4% changes, reduction in A1C from baseline. I mean, for 10 years follow-up, this is quite remarkable. I want to emphasize one thing, which my colleague diabetologists might probably like to hear, and this is the fact that at 10 years, the medical therapy group had a reduction of A1C of 0.8%. This is not trivial because we're talking about 10 years follow-up. You know that diabetes over time, no matter what you do, gets worse. So the fact that we have a decent reduction from 10 years before, and it's very important. I think it does attest to the quality and the power of modern medications. I told you before, these patients have increased use over the last, the second half of this study of the most modern drugs, new GLP-1 agonists and SGLT2 inhibitors that are quite important and effective. And I think the medical therapy of today is better than the medical therapy we had to in the past. But it does mean that the medical therapy group was an excellent comparator for surgery, and it does attest to the power of surgical interventions. If you look at even the best medical therapy with excellent results, still don't match the glucose lowering potency of surgical operations. Weight loss, as you would expect, there was more weight loss in the surgical groups, but there are two things here I want you to realize here. One is we found no difference whatsoever in weight loss between BPD and gastric bypass at any time point of the study, from 2 years to from 6 months and all the way to 10 years. People might say, well, that looks very strange because BPD for surgeons is quite well known to cause more significant weight loss than gastric bypass. But I want to point your attention to the fact that in this study, we used BPD Scopinaro classic procedure. So this is with the horizontal gastrectomy, not with the sleeve gastrectomy. And also, I want to point out that the studies that have shown in the past that BPD is more powerful in the sleeve than gastric bypass in inducing weight loss, only looked at patients, only found the difference to be true in patients with BMI over 50. All of our patients had a BMI below 50, and in this patient's population, you are not going to see a difference in weight loss between BPD, at least the Scopinaro one, and Roux-en-Y gastric bypass. So this result is not surprising if you consider that. Another important thing here that I want to emphasize is the weight loss that you see in the medical group. This is about a 4% weight loss from baseline. At 10 years, I probably would venture to say that this is one of the best 10 years weight loss we have ever seen in patients with obesity, severe obesity and diabetes. If you remember the Look Ahead trial, they had 4% weight loss, but not at 10 years, and then they regained. So this means, again, that perhaps the use of SGLT2 inhibitors and GLP-1 agonists are doing an effect on weight that is visible and sustained at 10 years. And again, it's important because it means our medical group was well treated. Quality of life, it's very clear the difference between surgical and groups and medical groups is very, very clear. And this is not intuitive. A lot of people would, including myself, perhaps at the beginning, would have said, yes, surgery can be very effective, but at the end of the day, it messes up with your anatomy of your gut. You might have digestive issues. You might have all sort of side effect on your digestive system, and how does it affect your quality of life? The bottom line is that at 5 years we had exactly the same results. At 10 years we have the same results. Surgical patients have far better quality of life by all domains that we tested. And also there was a difference between Roux-en-Y gastric bypass and BPD, with Roux-en-Y gastric bypass patients having the best quality of life among the 3 groups. Now, this is one of the most important findings of the entire study, diabetes-related complications. So this study was not designed for diabetes-related complications. Normally, we would have expected that in order to see a difference in diabetes-related complication, you should have a much bigger trial. But it was a predetermined, predefined secondary outcomes, and we thought that this was mostly exploratory, to be honest. However, while at 10 years, we found a dramatic difference in the incidence of diabetes-related complications, both micro and macrovascular complications. You can see that the incidence of diabetes-related complications is very low in our groups. Now, obviously, these are a small number of events because the study is small, but the study, as small as the study was, it is the magnitude of the effect on diabetes complication is so important, so big, that you see a difference being statistically significant between groups. Importantly, this is a reminder that despite the good results, arguably good results in terms of glycemic control and weight loss in the medical group, patients still experience diabetes complications. This is known to be a problem. And the power of this glycemic benefits of surgery clearly must do something to the progression of diabetes. I think this is the first randomized clinical trial that documents a difference in diabetes-related complications. You might have heard about many studies before, case control studies showing better results with surgery, but there wasn't any randomized trial yet that could document differences in diabetes complications. This is a really significant, important finding, I think. If you look specifically at the what these complications were, you can see that there was myocardial infarction in two events in the medical surgery group. One of them was fatal. The patient died because of myocardial infarction. We had also in the medical group retinopathy, renal complications, neuropathy, as you would expect. This is the whole cohort and host of diabetes, typical diabetes picture. And it's impressive how you see a lot of zero here in the surgical group. It's quite remarkable. Now, importantly, none of the patients who had diabetes relapse had complications, just because not many people had complications at all. But it's important to note that, because that means that if you have a no relapse, so if you have if you have remission of diabetes for 5 years, or for more than 5 or 2 years, or more than 2 years, and then even if you have relapse, you're unlikely to develop significant diabetes complication. That means that is important. That's an important finding, because when we talk about long-term screening, this has relevance for insurance and etc. We might not need to make such an intensive monitoring and screening. We could probably, after 5 years of continued remission, we could possibly relax screening, maybe do once a year. That would be a big saving in terms of healthcare management of these patients. And also, of course, it would have a psychological impact on patients. Again, I'm not advocating to drop monitoring these patients indefinitely, I think it should be continued, but I think it doesn't have to be as intense as it is in in patients who have full-blown diabetes and uncontrolled diabetes. If you have remission for more than 5 years, maybe we can relax things. Now, what about surgical complications? We reported in this study all type of complications, from early postoperative complications like in the first month all the way to 10 years. And you can see that there were few complications at the beginning, as you would expect from surgical operations. And then there were no late complications after 2 years, 5 years. So we have not encountered surgical, typical technical complications that you would expect, like intestinal obstructions, et cetera, after in the long term. But we did found, as you also would expect, some nutritional complications, side effects of surgery, including hypoalbuminemia and osteopenia, osteoporosis, and some patients with symptomatic hypoglycemia, iron deficiency. But as you can see, the vast majority of this were in the group of BPD patients. There were fewer such incidents in the patients with Roux-en-Y gastric bypass, and in most of these cases, those adverse events were very mild. So at the end of the day, clearly there is a gradient of efficacy between BPD and Roux-en-Y gastric bypass, with BPD being more powerful. But in terms of nutritional side effects, BPD clearly has more risk of nutritional side effects, and quality of life also favors bypass. So if you put a trade-off between benefits and risks, possibly Roux-en-Y gastric bypass may be the procedure that has the best risk-benefit profile, even though, interestingly, there is less remission than with BPD, admittedly. Briefly, the medication usage, you can see from baseline all the way to 10 years, as you would expect. Patients on a medical therapy group increase the use of insulin slightly over time, but they also increase the use of injectable medications altogether, because they include GLP-1 analogs. And you can see the pictures in the surgical group is remarkable. Very, very few people, patients, if any, were requiring insulin. Actually, none of them in the BPD group, and maybe only one in the gastric bypass group. The rest were very well managed with minimal medications. These are medications for diabetes. The same difference is statistically significant. We're seen in any other type of medications we call cardiovascular medications, including medications for lipid control or hypertension medications. And for all of them, there is a dramatic difference between surgical and medical patients. This might have much relevance in terms of cost effectiveness, as you would predict, of course. So finally, just a couple of considerations here. Weight loss and diabetes. In this study, weight changes did not predict diabetes remission, nor diabetes relapse among surgical patients. Specifically, there was no difference in weight regain at 10 years between the patients who had remission, sustained remission, and those who had relapse. You also have seen that there were differences in remission between BPD and Roux-en-Y gastric bypass, but there were no difference in weight loss between those two procedures. So this is very important, because it is in contrast with what we have seen from traditional bariatric surgery series, where weight loss correlates with diabetes remission. In this case, it doesn't. We also found that duration of diabetes did not predict remission or relapse, use of insulin either. So the question is why? I think the reason is because when you look at bariatric surgery, you have the vast majority of patients with diabetes, which are fewer than the majority than the whole group of bariatric patients. But in those patients with diabetes, the vast majority have very early diabetes, recent diabetes. They're not taking insulin. They're not taking many medications. And so it means you are operating by and large on early diabetes, mild diabetes. this study has a very homogeneous severity of diabetes across groups. And in this case, you're not going to see a difference in insulin factor, because obviously 50% of them were already on insulin at baseline. And because diabetes is more severe, it's more advanced, perhaps weight loss is no longer a factor as it is in traditional bariatric surgery patients. So not very surprising. The fact that there was more remission with BPD and the weight loss was identical to gastric bypass suggests that there are weight-independent effects of surgery, that BPD simply is more able to activate and engage than Roux-en-Y gastric bypass. Why BPD has this effect on glycemia, we don't know. Is the longer bypass of bowel that is at play, or other factors? Of course, this study was not set up for finding out, but it's an interesting finding. I want to also conclude with, again, this emphasis on diabetes as a curable disease. I think I don't take the word cure of diabetes lightly. You might, especially diabetologists, might look at me a little bit strange. But believe me, I published this paper in 2002 where I say potential of surgery for curing type 2 diabetes. And I say potential. I thought it was an hypothesis. Now, a few years later, in 2009, I was interviewing a major TV show in America, and the host told me, "You published this paper. You clearly believe surgery is a cure for diabetes, and diabetes is curable. Can you answer yes or no? Is this a cure?" I answered no to that question. And I said, I can't claim a cure because we don't know the cause of diabetes. And so if you don't know the cause of diabetes, you can't tell if you have cured it. But 20 years after this paper, I do think we have now reasons to use the word cure because I think you don't need necessarily to know the biology of a disease. We don't know, for instance, when we talk about a cancer being cured at 10 years, we don't know that there is no cancer cells in the body. We just know that those cancer cells are not able to create disease and to harm the patient. And we call it clinical cure. So I think likewise, we should start entertaining the idea that diabetes can be at least clinically cured. And to some patients, this is an important message, because if we are not able to give an evidence-based diagnosis of disease, if there is no sign of disease whatsoever for 10 years, while not telling patients that they might be clinically cured, that doesn't mean that they will not have diabetes, because they could have another time diabetes, like people who have cancer in one breast, they can have cancer again in the same breast or another breast, and lung cancer can come again even after a clinical cure. So we're not saying that they will never have diabetes. They should be considered also always at risk, but giving them a chance to be feeling free of disease, I think it's also a patient right. So today, I think I feel much more comfortable than I used to in saying diabetes is curable, not in every patient, but in some of them is. And I want to finish with this conclusion, which is the conclusion of our study. This is the conclusion we made and that Lancet has put on their cover page. Now, let me say that for me, after 20 years that I've been working in this field, looking at a quintessential medical journal like the Lancet, certainly not a surgical advocate, that puts on the front page that metabolic surgery is more effective than conventional medical therapy in the long-term control of type 2 diabetes. I think it's a recognition that the evidence is now compelling. The evidence is quite definitive that we have a major opportunity to treat diabetes effectively, and in some patients, this might be a life-saving option. I'm not thinking for a second that surgery could ever be the main approach to 400 million people with diabetes around the world. But ignoring surgery in 2021 is no longer an option. Any GP, any diabetes care provider that takes care of diabetes must be familiar and facile with every available therapies of diabetes, and tell patients that for some of them, they could go back on lifestyle interventions and that will do fine. But for those who do not respond, not suggesting and recommending surgical interventions, I think starts to become a problematic issue. I think everybody should know about this, and I hope we'll be able to inform our colleagues and the patients at the same time. Thank you very much for your attention.
Thank you very much, Francesco. Outstanding presentation and study. It was awesome. Now, I will introduce the chairman and the panelists of this webinar. Doctora Marianela Aguirre Ackerman, médica especialista en medicina interna, nutrición y diabetes, profesora adjunta de la Facultad de Medicina de la Universidad Nacional del Nordeste, directora y docente de cursos y diplomaturas en obesidad, bariátrica y diabetes de la Universidad Favaloro, Sociedad Argentina de Nutrición y Sociedad Argentina de Diabetes, directora del Departamento de Nutrición y Diabetes del Centro 100, coordinadora del Grupo de Obesidad de la Sociedad Argentina de Nutrición y del Comité de Clínica y Nutrición de la SACO. Muchas gracias, Marianela, por estar con nosotros. Quiero presentar también a la doctora Tarisa Sanata. She's an endocrinologist at the Obesity and Diabetes Center of the Alemán Osvaldo Cruz Hospital in São Paulo. También quiero presentar a la doctora Silvia Lapertosa, médica especialista en nutrición, profesora titular de Nutrición y Educación para la Salud y adjunta de Medicina 2, Facultad de Medicina de la UNE, presidenta actual de la Sociedad Argentina de Diabetes. Y por último, quiero presentar a la doctora Carla Musso, endocrinóloga especializada en diabetes en la SAD, coordinadora del Servicio de Diabetes de la Fundación Favaloro, endocrinóloga del Hospital Milstein, investigadora clínica del NIH, directora diplomatura en diabetes en el SAD y la UNE. Well, I would like to know, Marianela, es todo tuyo.
Well, thank you, Francesco, for your wonderful presentation. I have two questions to you first. The first question is, what are the strengths and the weaknesses of your trial? This is like the first question.
Well, first of all, thank you. As any study, there are limitations and there are strengths. I think the limitations are the small sample size in the first place. The fact that this is a single center study, is not a multi-site trial. And obviously the open label design. So in other words, obviously we knew what patient had. The problem is that a study like this cannot be blind. You can't blind the patient whether they had surgery or medical therapy. Even blinding the clinicians would have been very easy to break to break the news about what the patient had. And also we couldn't blind patients as to whether they had BPD or bypass, because one was laparoscopically, one was open. We also know that BPD gives particular severe complications in terms of full smelling stools and other things that were described to patients in for the consent. So obviously patients would know what they had. So it is the inevitable limitation of the study to be unblinded. And so that's one. However, we did make an effort by design to make sure that the patients were assessed clinically for the study purpose. Of course, they were seen by surgeons to rule out complications, but the assessment for the study was made by non-surgeons. So it was diabetologists that made the assessment and endocrinologists. So at least we don't have a professional bias towards the interventions that actually was found to be more effective. So normally, so that's the limitation. I think the strengths of the study include the fact that retention rate, small as it is, with a retention rate of 95% and more, I think that's quite robust to tell us what happens in the long term. The long term data is another strength. And as I said, it's not very common in surgery you have a long term study like this. I think and finally, I think the medical therapy in this study was remarkably effective, which means that we had a good comparator for the efficacy of surgery. So that's my assessment. Of course, I'm sure there may be more limitations that others could pick.
Thank you, Francesco. And the second question is, in your study, surgery induced 10 years remission of diabetes in 37% of patients. This is an excellent result, but what are the reasons why remission rates were lower than 50 to 80% reported in several retrospective series of metabolic surgery?
Well, this is an excellent question. A lot of, first of all, yes, if you look at historical series, normally it's 80% or 70 to 90% remission rates. Now, first of all, we're talking about 10 years follow-up. Many of those 80% refer to earlier follow-up in most cases. However, there are other studies that looked at long-term follow-up after bariatric surgery, like I remember from United States, 12 years follow-up after gastric bypass in patients with diabetes. There was a 52% remission, so more than what we found here. But again, as I say to you, bariatric surgery is not the same type of patient population that we had in this study. If you have patients with early onset diabetes, you're probably going to have higher rates of remission. The low remission rates we have here is probably due to the fact that all patients by design had a more advanced disease than we normally see in bariatric surgery. And so that's very, very, I think it's one of the explanations of why you have less than what you expect. But I want to point out something that my colleagues here in South America, maybe surgeons in South America may remember. Once we started to say we should use surgery for diabetes because it's not about weight loss, etc., some surgeons started, especially in South America, using surgery in patients with lower BMI. And in patients with lower BMI, at the beginning, remission rates were not 80%. They were 50, they were 55 or something like this. And all of a sudden, surgeons said, oh, surgery is not so effective in low BMI. Well, what they were seeing was not the lack of efficacy because of the BMI, but what they were seeing is that the patients with low BMI came with real diabetes, versus the patients with high BMI in traditional bariatric surgery had a less severe one. And now you can see that 37% remission rate is no different than Ricardo Cohen DJB in low BMI patients that he did many years ago, and he found something around 50% or so. And some people around the world were saying, oh, this is not as good. It means you should not operate in the low BMI patients. No, it's exactly what you would expect from a more severe diabetes. So that's my take on these findings.
Okay, thank you, Francesco. Pedro, do you want to perform some question from the public to Francesco?
Okay, some question from Matthias. Were some patients excluded from the study due to long history of diabetes? There was a maximum of diabetes history in years?
No, we didn't. We had a minimum of 5 years, but no maximum duration.
Okay. Have you accessed pancreatic reserve and function prior to surgery in patients recruited?
No, there was not a predetermined outcome measure. However, I do think that probably some of these patients did have C-peptide because in Rome, my colleague Geltrude Mingrone very often measures C-peptide as a routine marker, but it wasn't part of the study.
Okay. Ines asked, in the group that had a medical therapy, were the lifestyle change intensive or standard treatment?
Difficult to say what is intensive or standard. It's very subjective. What I can say is that the lifestyle interventions these patients had is way more than they would ever have in normal clinical practice because they were followed by dietitians, they were instructed, they were repeated. I don't think it's safe to say that in standard clinical practice, you would not have the same type of input for lifestyle intervention. Whether this is intensive, or there are other type of studies that looked at intensive, more intensive than this. Yes, I think there might be more intensive lifestyle interventions, but don't forget that studies like the study by Dr. Cummings and colleagues in America, and also Dr. Goldfein at Harvard, they used very intense lifestyle interventions in randomized trials of surgery and medical therapy. And at 2 years and 5 years, those lifestyle interventions had not even close to the effect of surgery. Now, if they were not effective at 2 years, I would submit that you wouldn't expect lifestyle interventions, no matter how intense, to have an effect at 10 years.
Okay, thank you. And the last question, then we go to the panelists. Why didn't they include diabetic patients with BMI between 30 and 34?
Good question. At the time in Italy, in Rome, it was not possible to operate those patients normally. And it could have been done in a clinical trial, but it was decided to focus on diabetes for patients that we knew, if the study was positive, could have immediate access to regular standard coverage of surgery. So this was a pragmatic kind of study, but yes, could have been interesting to do it for lower BMI as well. But we didn't.
Okay, perfect. Okay, Marianela?
Well, we move on now to our brilliant panelists. The first question is for Silvia. Silvia, la diabetes es una enfermedad que está aumentando de manera exponencial de la mano de la tasa tan elevada de obesidad. Vos que estás en la Sociedad Argentina de Diabetes como presidenta, ¿qué nos podés decir con respecto a la situación epidemiológica de la diabetes en Argentina y en Latinoamérica?
Bueno, buenas noches a todos. Sí, realmente es sumamente interesante porque ante esta epidemia de diabetes y obesidad que tenemos en Latinoamérica y en el mundo, esta opción, ¿no es cierto?, de que realmente cambie el futuro de nuestros pacientes va a ser muy importante. Hoy nosotros tenemos la suerte en Argentina de tener datos desde el 2005 hasta el 2020, porque se ha hecho la encuesta de factores de riesgo siempre con la misma metodología, y la diabetes en este momento, la prevalencia es de 12.7%. Lo preocupante es que en el 2005 era del 8.4%, es decir, que ha sido un aumento muy importante. Esto va de la mano, como vos bien decís, Marianela, del aumento de la obesidad. El exceso de peso pasó de, estamos en este momento casi en el 62%, sumando sobrepeso y obesidad. Lo preocupante en el tema de la prevalencia es que la encuesta hizo morbilidad percibida, pero también hizo mediciones antropométricas. Y hay una diferencia entre lo que percibe la gente como obesidad de lo que dio realmente cuando se midió. Hay una diferencia del 6%, es decir, que hay un porcentaje de la población que no se reconoce con exceso de peso con obesidad. El otro tema es que estamos en Latinoamérica casi en un 10% de diabetes, la mitad de esa población no sabe que tiene diabetes, y lo otro interesante es que hay otro 10% de personas que están en un ambiente de prediabetes, es decir, que eso significa para Latinoamérica 50 millones de personas. Para los próximos 10 años va a haber un incremento del 55% de personas con diabetes en la región de Sudamérica y Centroamérica. Y después tiene que ver también la parte epidemiológica, que ¿qué pasa con la mortalidad de estas personas con diabetes y obesidad? Primero, el 80% de las personas con diabetes 2 tienen obesidad, y 4 de cada 10 muertes relacionadas con la diabetes son en menores de 60 años, es decir, en plena etapa laboral. Y el tema también interesante es lo que esto significa en los gastos. La región Centroamérica y Sudamérica ha gastado en la atención de las personas con diabetes 70 billones de dólares. Realmente un impacto desde el punto de vista de la salud pública y de la economía de los países. Y creo que también un tema epidemiológico que tenemos que tener en cuenta es que no es solo las personas ya con diabetes 2, sino qué nos pasa en las mamás que tienen también una alta tasa de obesidad en el momento del embarazo, y se dice que somos lo que nuestra madre comió mientras estuvimos en el vientre. Entonces hay un impacto transgeneracional de esa mujer obesa durante el embarazo que va a impactar en el futuro de ese niño haciendo de que aumente tremendamente la prevalencia de diabetes y obesidad. Yo te quiero dar un dato también que es interesante en el estudio que abarcó 65 millones de participantes en 200 países. Dice que Argentina y Latinoamérica aumentaron en los mayores de 19 años 2.5 el BMI del 85 al 2019, y Brasil aumentó 3 puntos el BMI. Realmente un impacto sumamente interesante, y me llamó la atención en ese trabajo que compara Estados Unidos y Nueva Zelanda con la África subsahariana. Dice de que se acortaron en talla, pero aumentaron en peso. Es decir, países tan adelantados y tan desarrollados se comparan con otros de prácticamente del subdesarrollo. Es decir, hay una obesidad también impactando en la malnutrición de esta población. Es decir, son más petizos y más obesos. Así que realmente es un panorama bastante preocupante si uno no toma realmente una conducta terapéutica adecuada, ¿no?
Gracias, Silvia. Muy interesantes los datos. Y ahora vamos a una pregunta para Carla. Carla, do you think that metabolic surgery is considered in the management of patients with obesity and type 2 diabetes? What is the place of metabolic surgery, in your opinion, in the treatment of diabetes now? And what is the place that, in your opinion, it should have?
Yeah, well, I believe that metabolic surgery is not being considered as a tool. And if we take a look at the numbers, for example, if you look at the publication of Dixon, even when it's not recently, because it's 2016, we can see that they accept, and this publication was from Australia, and it's a survey of 22 countries, and 19 of them, they have guidelines for metabolic surgery. But even though that, they have that less than 1% of the patients went to get the metabolic surgery. They are eligible, but they just 1% get the surgery. So I believe that the metabolic surgery is the last option, and sometimes it's not even an option. So I think that we need to take a look at the patient, to take a look at the beta cell mass function, and we need to do the surgery with C-peptide, and we know that the results, or we believe that the result will be much better than we have the results now with this patient with exhaust beta cell function.
Thank you, Carla. Teresa, what is the place of the metabolic surgery in the treatment of diabetes in Brazil now, at the moment? And what is the place that, in your opinion, it should have?
Thank you, Marianela. Congratulations, Francesco, for the presentation and for this important paper. In Brazil, there is an official guideline where patients with uncontrolled diabetes and BMI above 30 may undergo metabolic surgery, but the payers don't cover yet. We are struggling for that.
And what is the place that, in your opinion, it should have?
Okay, I think that metabolic surgery needs to be, we have to talk to our patients about metabolic surgery as one kind of treatment of diabetes, the same way we talk about medication. If patients is uncontrolled, we have to think about metabolic surgery as an important treatment to focus on reducing diabetes complication and improving quality of life and survival.
Thank you, Teresa. Carla, in the evolution of type 2 diabetes, where do you think metabolic surgery should be included? If we imagine a treatment algorithm for diabetes, where would you place metabolic surgery?
Well, definitely, I think we need to think about metabolic surgery before beta cell apoptosis. So maybe after 3 drugs, if with 3 drugs we can take the diabetes under control, we need to think about metabolic surgery before insulin, and definitely before intensive insulin therapy, because otherwise we have no beta cell, and the results, even when we will have good results, it won't be the better result that we can have if the patient have a beta cell function available.
Thank you, Carla. Silvia, así como es importante elegir el momento en la evolución de la enfermedad, y eso es resorte, por supuesto, del médico, diabetólogo, endocrinólogo, otro de los roles importantes que tenemos es después de la cirugía. ¿Cuál es el rol y cuáles son los recursos con los que contamos hoy para mejorar la adherencia de los pacientes al seguimiento? Como vimos, Francesco tuvo una adherencia altísima en el seguimiento, que no es lo que habitualmente vemos en la práctica.
Sí, realmente es sorprendente. Bien que los pacientes están en un protocolo y eso permite también el seguimiento, pero sin duda el tema de la adherencia es un tema muy complejo en las enfermedades crónicas. Hay publicaciones que dicen que de las personas que tienen diabetes, la mitad no sabe que la tiene, de los que la tienen, la mitad se trata, y de los que se tratan, solo la mitad tiene un buen control metabólico. Así que en el tema de la adherencia es un tema serio. Yo creo que el centro más importante es el trabajo multidisciplinario previo a la cirugía y posterior a la cirugía. Si el paciente no tiene un buen convencimiento cuando va a ir a operarse, después de la cirugía es muy difícil ganarlo. Y creo que el trabajo desde el punto de vista de los talleres de nutrición, las licenciadas de nutrición, la intervención de la terapia conductual tiene que ser muy importante, trabajando metas y objetivos que sean alcanzables y medibles. Yo creo que una estrategia también es cuando uno categoriza el riesgo cardiovascular previo a la cirugía, y cuando uno lo muestra en la tabla de cómo va bajando ese riesgo. Es decir, no es lo mismo tener un 40% de riesgo de hacer un evento cardiovascular en los próximos 10 años, que con bajar de peso, estar mejor controlado, ese riesgo baja al 10%, es un impacto educativo para la persona. Y yo creo que el equipo multidisciplinario tiene que ser como la historia del gondolero cuando le enseña a su hijo a manejar la góndola, ¿no? Es decir, es el tutor, es el que lo va guiando por los canales, y yo creo que ese es el lugar que tiene que tener. Y tenemos que tener muy claro de que no es lo mismo adherencia que compliance. Compliance es que el paciente haga lo que nosotros queremos, y eso nunca le cambia la cabeza. La adherencia es cuando el paciente se empodera y es capaz de tomar el camino que es mejor para su salud y para su mejor calidad de vida, ¿no?
Gracias, Silvia. Teresa, what do we do with metformin after surgery, in your opinion? And how do we manage the patient with medical treatment if they don't achieve remission and they maintain blood glucose levels above target?
Okay, we are very liberal using anti-diabetic and cardiovascular medication after surgery. Because our focus is on keep diabetes under control, reducing micro and macrovascular complications. We only withdraw metformin when patient has some gastrointestinal side effects, or have some kind of hypoglycemia or something like that. We only don't use SGLT2 inhibitors early after surgery because the risk of ketoacidosis. But we can use it again after patients is on a regular diet. So we keep the medications.
Okay. Thank you, Teresa. And Carla, what in your opinion should be the criteria of remission we should consider after metabolic surgery? And what is the importance of using one of other remission criteria?
I think a good remission criteria was presented last year at the ADA. with, it's not published yet, but with hemoglobin A1C less than 6.5 and 6 months without medication. But I would like to know Francesco's opinion about that. I think that will be important for us.
So I had the privilege of being part of the ADA committee that made the first definition in 2009, and I'm also involved in the ADA and ESD committee that is now revising that definition. As you said, 10 years ago, when we first said 1 year, many of us were not very comfortable with that, because 1 year is very arbitrary. And it's impractical to use. 6 months has a biological rationale. It's 2 cycles of A1C changes. If you have one, only 3 months may be too short because you might not have seen enough. But 2 of them should be enough for you to start thinking about being in remission. So probably that's what I can anticipate. This is going to be the new definition. The paper will be published soon. And the new definition will be A1C less than 6.5. There will be no 6 or 6.5, 6.5 only, and less than a 6 months duration, no longer 12 months.
Okay.
And what I think it will be important is to demonstrate that surgery is a useful tool also to be included in the medical insurance. So we need to demonstrate to people who are in the healthcare system, that this is a good tool and maybe cost effective, and they need to include it, and they need to pay for us for that. I mean, the insurance need to pay for the surgery.
Yes, and it's important to know that it will be a new remission criteria, more homogeneous, because we have a lot of criteria: partial recovery, complete recovery, prolonged recovery. This is not easy to understand. There are more than 96 different definitions of remission. So it is important to take one remission criteria. Yes. Silvia, la diabetes es una enfermedad metabólica que tiene un alto impacto en la salud de la persona. Siempre hablamos del impacto en la salud vascular, pero la diabetes es mucho más que una enfermedad vascular. ¿Qué nos podés decir del impacto de la diabetes en la salud de la persona?
Bueno, como vos bien decís, tiene un impacto en el árbol micro y macrovascular, en los órganos diana considerados como paradigma de la diabetes, ¿no? La nefropatía, la retinopatía, la enfermedad cardiovascular. Ahora hay otros órganos no habituales que también se están impactando en las complicaciones de la diabetes. Creo que una de ellas es el tema de cáncer, ¿no es cierto?, que llama mucho la atención, la asociación de obesidad-diabetes con el cáncer. Es mucho más frecuente la presencia de hepatocarcinoma en el hombre, que incrementa el riesgo de tener cáncer hepático si tiene asociado diabetes y obesidad. Es el primer caso. Hubo 800.000 nuevos cánceres atribuibles a la diabetes con obesidad. Y en la mujer es mucho más prevalente la presencia de cáncer de mama y de endometrio en segundo lugar. Casi son el 50% de esos cánceres nuevos que hubo. Realmente eso es preocupante, ¿no es cierto? Y por otro lado, tiene que ver con que, por ejemplo, en la enfermedad coronaria, en la insuficiencia cardíaca, en las enfermedades de las arterias periféricas, esa prevalencia va del 16 al 30% de las personas con diabetes ya con complicaciones. Y el accidente cerebrovascular tiene una prevalencia también de casi el 10%. Ahora, nosotros tenemos esas complicaciones habituales que estamos conociendo y que muchas veces lo hemos leído y discutido. Pero hay otras complicaciones que se dicen no habituales. Por ejemplo, a nivel de la retina hay una neurodegeneración retinal, que hay alteración, es una neuropatía sensorial, que afecta la visión del color y la visión en la oscuridad dentro de la diabetes. A nivel de renal tenemos una lesión túbulo intersticial, que entonces no solo es una glomerulopatía, sino una túbulo intersticial. A nivel cardíaco tenemos no solo el accidente, el infarto y la enfermedad cardíaca, sino la neuropatía autonómica, la denervación cardíaca, que a veces es esa típica muerte súbita, muerte en cama, la miocardiopatía diabética, y también tenemos lesiones a nivel cerebral, donde es más frecuente la demencia, parece ser tener relación la enfermedad de Alzheimer. Cuando uno ve imágenes, ve los infartos lacunares que tienen que ver, ¿no es cierto?, con trastorno cognitivo. Está afectado el pulmón, porque hay una microangiopatía pulmonar, que trae hipoxia, y por supuesto el hígado graso no alcohólico, que es otra de las morbilidades que tiene la persona con diabetes. Es decir, que hay una afectación de todo el organismo de la persona con diabetes tipo 2, y por supuesto afectada con la diabetes. Así que lo que mostró Francesco de una reducción del riesgo de 14 puntos de las complicaciones micro y macrovasculares producto de la cirugía metabólica, evidentemente muestra la mejoría, ¿no es cierto?, que estos pacientes tienen en lo que sería la prolongación de la expectativa de vida.
Muy interesante, Silvia, y sobre todo porque por primera vez tenemos un estudio, teníamos muchos estudios a largo plazo, pero retrospectivos, o prospectivos, pero no randomizados, como por ejemplo el SOS, pero tenemos por primera vez un estudio randomizado controlado que tenga 10 años de duración. Entonces, como bien decís, como decía Francesco, por ahí el número, el N, es pequeño como para poder hablar de un impacto importante en los números, pero sin embargo ya nos muestra, es como una muestra que nos muestra por dónde va el camino. And Carla, what is the impact of surgery on the evolution of complication of diabetes?
Well, it was demonstrated not just by this study, but other studies, many other studies, randomized studies, that the macro and microvascular complications decrease with metabolic surgery. So I think that's why it's a good reason to include metabolic surgery as a tool in the algorithm of diabetes therapy.
Thank you, Carla. There are no more questions to our brilliant panel of medical doctors from Argentina and Brazil. Thank you, Carla. Thank you, Silvia. Thank you, Teresa. And well, Pedro, do you want to perform more questions to Francesco?
Yes. I have a question from our friends, Ricardo. Francesco, treating type 2 diabetes is not glycemic control only. You are surely aware of today outstanding weight loss outcome of the step 1 trial, like 2.4 milligram of semaglutide, and the good cardiovascular and renal outcome with SGLT2 inhibitors and GLP-1RA. Are the new drugs mainly the combination of those inhibitors game changers? Will they affect the already low penetration of surgery?
I think it's a great news that we have a drug now that can give 15% weight loss in many patients and up to 20% weight loss. These are data just published in New England Journal of Medicine yesterday. It could only be a good news. I think we will have to move in the future towards a different way of treating these patients. Having more effective drugs, very effective surgery means we should just become a bit better in understanding how can we select and prioritize patients for surgery, because we surgeons will never have a chance to operate all the patients that are there. So if we know that we can have patients that can benefit from medications and can do well on them, that's great. We should take care of the patients that otherwise could not do without surgery. That should be our purpose. I don't think there is a problem of whether the surgery will be obsolete anytime soon, because the magnitude of potency of surgery is far beyond any medication that is currently available or even in the pipeline. However, the effects of the medications today are good enough for people with moderate obesity, for people with maybe non-severe diabetes. If they respond well and they're having good weight loss and they're not super obese, why would you consider surgery? I would just go for a medication. If I were a patient, I would prefer to have a medication. But there are some patients who need surgery. And I think we should make sure that those get access to surgery. It's no longer possible to have 99.9% of people who need an operation not having it. It's just not sustainable.
Okay. Here a question about the technical aspect. Did you change something in the gastric bypass technique? I mean, right now from that's 10 years ago, for example, did you change the bilipancreatic length or the pouch size for those patients with metabolic surgery?
No, I personally continue to do the bypass just the same way as I did it 10 years ago. We did publish in Diabetes Care a few months ago online. It's going to be pressed in paper. Another randomized trial looking at two variants of bypass, one with a standard limb, 50 centimeters of biliary limb, and one with 150 centimeters biliary limb. At 1 year, we found no differences in diabetes remission. We are now looking at longer term follow-up to see if in the long term there is more maybe relapse with the shorter version of the limb, or we don't know yet. As of today, there are no reasons to change the technique.
Okay, perfect. Well, we don't have any other question here.
We have another question about nutritional complications, about BPD. So the question is if we have, we could recommend BPD instead of gastric bypass, about the results, but the question is with concerns about nutrition deficiencies.
Well, this is a very good question. I think the study shows that BPD is extremely powerful for glycemic control, but it also shows, even in a small study, that is much more likely to induce nutritional complications, especially symptomatic nutritional complications, because even when gastric bypass patient had some iron deficiency or lower calcium, etc., it did not result in clinical syndromes. But in the BPD patients, you have actually the clinical syndrome associated with malnutrition. So it is problematic in terms of nutritional side effects. There are also many side effects, gastrointestinal side effects that patients reported. So they were reported more frequently with BPD. When you look at quality of life, which is a surrogate of all those things, probably people who have some more complications of this nutritional or that are clinically relevant might also be affected in their quality of life. And in fact, people with bypass had better quality of life than people with BPD. The other thing you need to look at is when you look at remission, sure, it's a great thing, but I also showed you what happens in patients who did not have remission. First of all, 87% of the patients across the board had A1C less than 7.0 with very little or no medications, maybe just metformin, okay? Many patients who had relapse, so more patients had relapsed with bypass, but those patients who had relapsed were still with A1C less than 7.0 with just metformin or nothing else. At that point, even if there is a difference in remission, I'm not sure it's so important to, given the fact that gastric bypass still has excellent glycemic effects, to justify the risk of nutritional side effects. So all in all, I think gastric bypass is probably the better option for most patients. I would reserve BPD for patients who have very high BMI, where like 80 or something, that you're not going to achieve at least a good weight loss for quality of life and other purposes. But for the purpose of diabetes in patients with BMI less than 50, I'm not sure the BPD would make a better option, even if remission is more likely.
Francesco, Ricardo Cohen, gastric bypass lover, he's very happy to hear you.
I'm sure, but don't tell him. Don't tell Ricardo what I'm saying.
Okay, the last question, because we are on time. Since weight loss was not a factor to predict diabetes remission or relapse, Do you think your data open new door to trials in non-obese patients, maybe with other kind of surgeries?
So our data cannot open to other kind of surgeries because simply we didn't test other kind of surgery. So we tested standard bypass. I'm not sure we need after 20 years, I'm still not convinced that we need to intensively look for other type of surgery. The surgeries we have are extremely powerful. They're very well tested. They've been tested for decades. I think what we need to be better at is to identify the candidates where we should prioritize surgery, and go faster and go quicker and go sooner. And that's what we should do at this stage. In terms of opening to low BMI, I've always thought that BMI is such an arbitrary thing. We should not even use BMI clinically because it's not a clinical parameter. It's an epidemiological parameter. BMI has no relevance whatsoever with a disease state. It could predict if somebody will have disease in the future, but if you have disease today, it really doesn't make a difference. If your BMI is higher or lower, you've got a disease. So you're already past the point of risk. So you need to use other parameters to measure the severity of diabetes, or to measure the predicting factors of recurrence or remission or benefits in general. So I think we should move away from BMI. I think we could and should operate in patients with BMI below 35. There is other studies that show that surgery is effective. And if surgery is not medications are not effective in some patients, I think we do know now that surgery could still have a chance to be effective. If we had to stop it just because BMI is not below, above 35, I think we wouldn't do a good service to patients. It's just not nonsensical to use BMI.
Okay, well, thank you very much, Francesco, Teresa, Silvia, Carla, Marianela, for this wonderful night. And finally, a farewell from the Executive Director of IFSO Latin American Chapter, Sergio Aparicio.
First of all, I'm going to speak in Spanish for all our Latin American attendees. Pedro, Marianela, Silvia, Teresa, Carla, muchas gracias por organizar este evento científico realmente importantísimo. A todos nuestros asistentes les agradezco por la participación. Estoy seguro de que nos hemos llevado un importante aporte esta noche. Francesco, thank you very much on behalf of Dr. Estuardo Berens, our president, because you are still awake at this time in London. I think it's near 2 o'clock in the morning of tomorrow. And thank you very much. This was a great presentation. Thank you very much. Keep safe. Chao a todos, nos vemos en una semana.
Gracias a todos. Chao, Luis.
Gracias. Thank you, Francesco.
Thank you very much.
Great presentation.
Gracias. Chao.
Chao.
Feliz Día Internacional de la Mujer Médica, que es lo que me acabo de enterar. Así que a todas las chicas, feliz día.
Gracias.
Gracias. Chao, Teresa. Chao, Carla.
Chao.
Chao.